Hello, everyone. My name is Funmi, and like Drew mentioned, I work at the Box Group Clinic as the pelvic health specialist, and I have a special interest in looking after women. And now with the menopause and perimenopause going around now, and there's a lot of things going on, we just felt we should just discuss what the menopause is and educate women generally. Yes, this is not to replace medical consultation. So if you have anything after the talk, please make sure you seek medical help. Talking about, so the reason why we've decided to do this talk is to give women the information and stop all this scaremongering going on. Because most times when women have menopausal symptoms, there's all you get, in the media and what's going on is, oh, don't take HRT, don't do this. You're just starting menopause, you're going to be in misery forever. No, it's good for women to just have that knowledge and know what menopause is. So, what are we going to discuss tonight? Before I talk in depth about the menopause, I'm going to show us the female vulva anatomy and just describe a little bit about the period and the events leading to menopause. And I will talk about the symptoms and the treatments that we can get when we are going through any of the symptoms. So let's start with the female vulva. Because when I talk to some of the patients and I say, do you know where the vulva is? They go, vulva, where's the vulva? They don't know where things are. So I'm just going to bring my cursor on the screen now. It's good we know about the vulva because the way I say to my patients, I say, think of your vulva like your face. If you look at your face in the mirror, so you need to look at the vulva. They go, oh, no, 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 that's a very private part of the body. And I say, no, it's just a part of the body. All parts of the body, can be private, but we need to look after the vulva very well because the menopause really affects the vulva. So let's go quickly through this anatomy picture. So that's where we have the mons pubis and the pubic hair. The pubic hair has a very important role in lubricating that area. And most times women are now shaving it off. It's very common that women wax it off. And I can remember in our dermatology clinic, we're like saying, oh, we're going to carry placards, bring back the bush, bring back the bush, because it has its role and it's there to lubricate the vulva and we should not be shaving it off regularly. And then we've got the clitoral hood there, and then we have the clitoris there, and we have the two lips, just before we go into the vagina here. And these two lips, we call them the labia, the big labia or the little labia. And just around that labia, this is all we call the vulva too. And then we have the vaginal opening that goes inside. We have the anal opening and we have the perineum. So all these area we call the vulva. And if we remove the vulva skin, we go into the pelvic floor. As women, we should know our pelvic floor. Everyone says, do your pelvic floor exercises, but we don't even know where these muscles are, and how to look after them. So I'll start with the picture to the left of the screen. So we've removed the vulvar skin here, and we can see the pelvic floor muscles. We have the urethra opening, that's the wee opening. We have the vaginal opening, and we have the back passage opening. And we can see all these muscles here, they are the pelvic floor muscles. So if we now get this woman to stand up in the next slide, and we look straight down, we can see the pelvic floor muscles quite huge. It starts from the pubic bone and goes all the way to the tailbone. And we can see it here supporting the pelvic organs. So that's one of its roles. And the pelvic floor muscles, we have the bulk of it at the back. So they have very important role. Many people think, oh, the pelvic floor is just in front. And how can that little muscle cause me problem? No, no, no. The pelvic floor is not a little muscle, it's huge, starts from the pubic bone to the tailbone, and the bulk of it is at the back. And now let's go now on to the events that lead to menopause. So I'll just quickly skim through, what the menstrual cycle is. So when we are born as girls, we all have all the eggs already in the ovaries. So these are the ovaries, these two. So these eggs are up to millions of eggs. By 7 years, the brain will now signal to a part of, we call it the hypothalamus, we signal to the pituitary gland to start making estrogen hormones by 7 years, to start getting the girl ready for puberty. So by 10, the eggs start to mature. So by 10 years, the eggs start developing. And then by puberty, the eggs will now be like 40,000 left, right? And then each month, the brain will talk to another part of the brain to speak to the ovaries to mature an egg, right? So that's the egg developing, and then the egg comes in, right? And while the egg is maturing, the lining of the womb thickens, right? Like in preparation for pregnancy to occur. But if there's no pregnancy, that's the luteal phase, then the egg is released. And then 7 days after, we have the period. And that cycle keeps going on and on until we start going through the perimenopause. The two important hormones that we need for this cycle to keep going on are the estrogen and the progesterone. The estrogen is what makes us feminine as women, right? It just gives us that feminine look. I always say to everyone, I said, look, the estrogen affects everywhere in the body from head to toe. So we've got estrogen all over our bodies as women. And by the time we get into our 40s, the production of estrogen starts declining, and then we start going into what we call the perimenopause and then to menopause. So, and I'll now explain what that menopause is now. So the average age, before I go into the average age of starting the symptoms of menopause, that's the perimenopause, is 47.5, and the average age when the period ceases is 51, and the life expectancy of the average woman in UK now is 81.2. So that means now we're living longer. We are no longer in the ancient period where women die like 40 something. They have like 10 babies and die off. So they don't know what menopause is. But now we are all living longer. So we are now going to be spending a big part of our life in menopause. So we really need to know how we look after ourselves. So let's go through the perimenopause, menopause, and everything. So the perimenopause, it varies in age. It can start from 40 and above. And the perimenopause is when, like I said, the estrogen is declining, and then you start getting symptoms, but you're still having period, but you'll be feeling, oh, why do I have this period? Why do I have this memory fog? Or why do I feel funny? Why am I sweating? But you are just working your way gradually into the menopause. And this can last up to 10 years for some women. And sometimes women will go to their GPs and they'll say, oh, we are going to do a blood test just to see what your estrogen level is. We now know it's not really reliable. The blood test is not really reliable because the level of estrogen varies at the particular point in time, during your cycle. And if you are going through the perimenopause, the periods can become very erratic, or they can even become longer, when you are bleeding, or they can just be short. So doing the bloods to find out if you are going into menopause is not really reliable now. And then when we now go into menopause, menopause is something we look back and we say, oh, do you know I've not had a period for a year? And that is it. That is menopause. No period for a year, and estrogen production stops. The ovarian function stops. So that is what we call the menopause. And someone was joking with me. She's an American. She said, oh, I was going to have my menopause party because it's been 10 months since I stopped having a period, but it just appeared from nowhere. No, you have to start counting again. So I don't know what menopause party she's having, but it has to be a whole year without any period. And that is where we go through the menopause. And the average age, like I said, is 51 years, but women can go through from 45 years to 55 years, we can have menopause. And some people have delayed menopause until like 58 years. Premature menopause is when a woman goes through menopause before the age of 45. So that's what we call premature menopause. And menopause also can be surgically induced or chemical induced or medication induced. So when we say surgical menopause is when we need to have our uterus removed for one reason or the other, right? The ovaries are still there, but if the ovaries is not feeding into the uterus, the ovaries shut down within 5 years. So for the fact that you have your ovaries, but as long as your uterus has been removed, within 5 years, you can go into menopause. But if you have your ovaries removed, you have the uterus removed, you have everything removed, you go straight into menopause. And that can be quite overwhelming for some women, especially if they were still having periods before they had all this, before they had the surgical procedure. So if you're still having your periods, maybe for one reason or the other, maybe due to cancer, and you have to have everything removed, there is sudden onset of menopause. And most times you notice that the gynecologist will want to prescribe HRT. Medication induced can be due to the side effects of chemotherapy or certain medications for cancer. They can cause, like menopausal symptoms. So that's just an overview of the terminologies we use with perimenopause, menopause, premature menopause. And there's one I've not really put here is when young girls stop having periods. We call it premature ovarian function. I've just put that in because we are not really talking about that. It's a very sad thing for a girl to know she's not just going to have children, so sometimes they have to put them on HRT so that they don't just go into menopause at a very early age. So now let's talk about the symptoms of menopause, because when we talk about the symptoms, all of us talk about, like the lady said, I'm on fire, I'm sweating, hot flushes, but there's more to that than just having all the symptoms of menopause. So the next slide is I'm going to go through all the slides one by one. So then let's talk about this first slide that what we call the vasomotor symptoms. This is more to do with, I'm trying not to use a lot of medical jargons. We call it like the autonomic system, what your brain controls, because there's a portion of the brain that drives the production of estrogen. And if this is not really driving the production of estrogen anymore, then women can get all these like autonomic like symptoms. And examples of these the vasomotor symptoms are hot flushes, which most of us know, or night sweats. And that's the most these two, the first two in this box, they are the most common symptoms women report. And another thing is sleep disturbances, right? And mood alterations, memory fog, just difficulty concentrating, forgetting things, putting post-it everywhere in the house and writing things everywhere. Or some people will even have problems with their blood pressure or low energy levels or palpitations. So these are all what we call together like the vasomotor symptoms of menopause. And these symptoms are the ones mostly treated by HRT or, change in diet or what we call like estrogen-like substances in your diet. So they respond more to that. There's evidence based on the clinical guidelines we have here for, we have evidence that HRT helps, but there's very little evidence for other things like the phytoestrogens, but some women say it does help. These three boxes here, where you have the purple icon, is one of the areas I treat women for a lot. That's the genitourinary syndrome of menopause and the sexual dysfunction and the exercises in terms of physiotherapy. So I'll first talk about the genitourinary syndrome before I talk about the sexual dysfunction. During the perimenopause, most women come to me, they go, oh, from nowhere, I just started experiencing recurrent UTI. It's like anytime I'm weeing, it's burning. But whenever I go to the GP and they do a dipstick test, it's negative. I don't know what's going on. It's all due to reduced estrogen. The pelvic floor muscles, they love estrogen. And that area, the urethra, the vagina, they have a lot of estrogen receptors there. And the estrogen receptors helps with the moisturizing effect we have in the vagina. It helps with making the cells very plump and they are very healthy. But when this starts reducing, then the vaginal tissues become quite dry, and then things can easily irritate the urethra during intimacy, or everywhere just becomes very sore and painful. So this is just one of the signs. We know that this is one of the signs of the perimenopause. And women don't even know that. They say, oh, I don't have hot flushes. I don't have anything, but it's just these vulvar symptoms that I have. And once we put them on vaginal estrogen and we tell them what to do, most symptoms improve. So we also have vulva, I showed you the vulva earlier, of vaginal itching. And some people actually have positive tests with their urine test, when they go to the GP. And what happens is because the urethra, or what we call the wee-wee pipe, it's more liable, it's opening more, like what I call is gaping more. It's not that it's just going to allow you to start, things to start tracking up, but we can easily get infection now that the urethra is a little bit open. And this can also happen more with intimacy when there's a little bruising, there's a little bruising of the urethra, then everything just sets up an infection. And also we can start experiencing, some women can start experiencing what we call vulvar changes. And that's why I always encourage, once we go to that perimenopause or menopause area, we need to be inspecting our vulvas regularly, because there's something called lichen sclerosis, or just whitish discoloration of the vulva. We need to start watching out for all those things, because menopause can cause that. It can also happen from excessive dryness, or maybe just from autoimmune diseases. And that's when some women will even also tell me, oh, do you know, for me, I was fine until I went through menopause. And all of a sudden, I was just doing something and I just felt something drop because the pelvic floor, they are not doing their supportive role again due to the decline in estrogen. And there's another thing some women will also, and with these symptoms, these can also affect the intimacy of a woman. You know, apart from the ovaries producing estrogen and progesterone, the, the ovaries also produce a little amount of testosterone. And testosterone is what gives us that sexual drive as women. And when we have that low level, sometimes, you know, we don't have good evidence. They want to replace it, but we don't have enough evidence to say, no, you give this lady testosterone. No, we don't. We don't use that to treat loss of libido. Instead, we start with, you know, vaginal estrogen and so on, and just encourage the women to eat other food and so on. But the estrogen, the ovaries produce a little bit of testosterone, and that can affect sexual function in combination with the reduced estrogen affecting the pelvic floor. And also, some women can complain of hair loss, excessive, you know, skin dryness, and as we get more into menopause, there's something called osteoporosis, which is just loss of bone mass. And because the estrogen we produce helps our bone to take in the calcium and just to help us with the bone, you know, we call it regeneration. So when we don't have that estrogen, the bones are not, they don't take up calcium easily. And for some women, this affects them a lot, and their bones can become a little bit brittle or porous, and that's what we call osteoporosis. And so women have joint aches all over their bodies. And as we get older and older, there's reduced muscle mass. And we already know aging also causes reduced muscle mass. One important thing most women have also is abdominal weight gain. Oops, sorry, abdominal weight gain. So, abdominal weight gain, you know, because we have the fatty tissue just being deposited, you know, in the abdominal area. And for some women, this can be quite excessive and is all due to loss of estrogen. And one of the gynecologists I work with said, I know the women that are on estrogen and the ones that are not. If they have a lot of abdominal fat post-menopausal, you just know that they're, you know, they're not metabolizing this fat very well. And they're not metabolizing um, they're not metabolizing their food well because of loss of estrogen. And then the fat is all deposited in the abdominal area. And also some women develop IBS-like symptoms like bloating, digestive problems, constipation, and so on. So there's a lot of things that can go on with lack of menopause, estrogen, sorry, lack of estrogen. So now let's go into um, a summary of what I've just said. Menopausal symptoms, I've listed a lot of symptoms there. It doesn't mean every woman is going to have that symptom. It's just for you to know the different types of symptoms that can happen during menopause. And everybody's menopause or perimenopause, it's individual. Previously, women tell me, oh, I'm just going to ask my mom, so my mom can tell me what happened to her. No, it doesn't work like that. Your menopausal symptoms will be different to your mom. It will be different to your sisters or your friends. Everybody is different. But we know most people, they can just tell you what they are going through, but it's not just going to be the same for you. The onset of menopause or perimenopause is different for each woman. The duration of symptoms is different for each woman. Everybody is different. Some people don't even know they've gone through menopause. They just go, oh, I've not used that sanitary wear because they don't have any symptoms. So everybody is different. And the severity of the symptoms is different for everybody. And treatments for menopause or the genitourinary symptoms should be based on individual presentation. That's why we don't use one blanket rule for everybody. And that's the problem with HRT, which I'll just touch on briefly about because there's a blanket rule and there's a lot of misconception about that. So now let's talk about management. I'll focus more on my own bit of the area that I treat a lot of women for, which is the genitourinary syndrome. So HRT, that's what is being called here, but there's a trend in America now. They're trying to change. We still call it HRT in UK because people go like, oh, if menopause is natural, why do you want to replace everything? No, we're not replacing your hormones. It's just hormone therapy. So, because people think, when I'm supposed to stop having periods, why are you putting in more things to make me feel like that? No, we're just, I call it, we're not substituting it, but we're just trying to, let me look for the right English. Is it, we are just trying to top things up a little bit so that you don't have severe effects of menopause. And there are various types of HRT. You need to see a menopause specialist to prescribe this for you, or you see a gynecologist with special interest in menopause to help you. If you go to your GP practice and you really think, oh, do you know, I've had enough of all these things and I want to, I want to start using HRT, and you need to ask for somebody with special interest in women's health. We don't have many menopausal clinics around, like the NHS menopausal clinic, but we have some gynecologists who see women, especially for the menopause. But please don't get discouraged if your GP says, oh, you don't need it, or come back again, or things like that. No, just keep going until you get what you want. And at the end also, I will put up some links where we can get help from. So alternatives to HRT. It's not everybody that likes taking hormone therapy, but there are other complementary therapies there. Um, there's herbal medication, but we don't have good evidence for that. But some women say it does help. I think there's something called, is it black cohosh or cohosh or something like that. Some women take it. St. John's wort, some women take it. They just say, oh, it does helps with my menopausal symptoms. And we also have all sorts of dietary therapies, phytoestrogen, soya beans, all sorts of diets to help with the estrogen levels. And there's something called cognitive behavioral therapy. It's also been approved by the clinical bodies here, like, we call it the NICE guidelines, that cognitive behavioral therapy helps with menopause. And the way it does it is just helping you to realize that don't look at menopause in a negative way, but think of it in a positive way. And that positive way, you can use it to help with the symptoms you're experiencing. And also, there are some GPs that will prescribe antidepressants, or some gynecologists, especially for women with estrogen sensitive breast cancer. I get some of my patients come to me, they say, oh, Funmi, I'm not depressed, but I don't know why I've been given antidepressant. And I have to explain to them that, look, we're not saying you are depressed, but it's just to help you with the mood, because maybe you can't take HRT because of other medical problems, right? But antidepressants are not the first line treatment for menopausal symptoms. So let's talk about dietary intake with menopause. I'll put a website up. I'm not a dietitian, but I just advise my patients, just the basic things about diet. Your diet has a lot to play in the menopause and the menopausal period. Sugar, especially. We feel very low in energy. We feel tired because of menopause. And then we take loads of caffeine to help us keep alive. We take lots of sugary foods to give us that energy. But actually, it's going to give us so much energy, we stay awake at night. Then we don't sleep at night. What happens? We are tired in the morning. So it's a vicious cycle. So I always say, don't take too much sugar, reduce your sugar level, reduce your caffeine, reduce alcohol, drink more clear fluids. That will help. Yes, I don't want you to have a boring life by just drinking only water, but just reduce all the other things that can help you, that can keep you awake, give you so much sugar and make you stay awake at night. I've mentioned phytoestrogens before, different types of food that can help, and adequate vitamin D, magnesium, and so on. And then probiotics. This is very good for the gut. Um, there are also some probiotics now, like we have various brands, but the two that I normally recommend for my patients are Optibac and Simprove. And Optibac, they have the Optibac Women that helps with the vaginal flora and everything. And the Optibac Gut helps with your digestion, especially if you have bloating and the rest. And Simprove is also very good. And then we move on to this next here, the vulva care, which is one of my areas of special interest. I always advise women to use what I call emollient wash. I'll show you some examples of the emollient wash in the next slide. To wash the vulva area daily in the shower. And after washing, just put a little bit. And then vagina moisturizers, they're good. pH lubricants, they're very good for intimacy, not pH, just let the pH be neutral. I'll show some examples. You don't want to use KY jelly because it's not really pH neutral and it dries off. And also with local estrogen therapy is good. These are vaginal estrogen, creams or tablets that we prescribe. And they also help. They have very little absorption into the whole body, unlike the HRT you take by mouth, that goes into your whole body. But the vaginal estrogen just act more in the vagina area. And always check the vulva and pelvic floor exercises. Every woman, every woman should do pelvic floor exercises, irrespective of your age, irrespective of whether you have children or not. As long as you are going to get older as a woman and you're going to go through menopause, you need to be doing pelvic floor exercises and maintain a healthy lifestyle, maintain a healthy weight, exercise regularly, and just some low resistance exercises. When we are going through menopause, that's not the time for very high impact exercises because sometimes they can predispose one to like prolapse. So you want to make sure you do your exercises regularly, gentle resistance exercises, but not excessive high impact exercises. There's one treatment I've not really talked about. It's called the Mona Lisa touch. I don't know much about it, but women come to ask me in clinic, and it's like a laser therapy into the vagina. It's meant to stimulate new collagen tissues, help with the growth, help with the the genital urinary syndrome of menopause. The evidence is still very low because it's quite an expensive treatment. It's not available on the NHS. It's more or less available privately in London and all these other places. So I don't really talk about it, but it's another option for the genital urinary syndrome. So A little bit of things here about seeking help. I'm going to skip through these. I'll point to where you can get these slides from. It's just to show us that a woman's relationship with menopause is complicated. Everybody is different, right? We need to know that we can get help. 50% of women don't seek help because they think, oh, it's a natural process. I should be able to go through it. No, if you're really having a lot of effects or if you're having a lot of symptoms or your symptoms are severe, please don't suffer in silence. Just seek help. Just seek help. And in terms of breast cancer risk and the HRT, I'll leave that more to the gynecologist to discuss with you. But I've just put it up here, as part of as I'm rounding up. Everybody is different. Before you think of saying, I'm not using HRT, talk to somebody who is experienced. I work closely with Miss Melanie Tipples, and she works at Spire Hospital. Sorry, she works at Northfield Hospital, Chichester, and on the NHS. She does menopause consultations. You can talk to her. And also, I did a lot of menopause workshop, and one of the doctors who taught me on the workshop is Dr. Karen Morton. She has her own clinic, is on the website. She's on the British Menopausal Society website as one of the menopause doctors. She's in Guildford. So these are people you can, you can talk to in case you need help. So to round it up, let's talk about the vaginal moisturizers, the emollients for vulva wash, and the lubricants. They're all different things. So these are all examples of emollient. They're just creamy wash. Don't use soap for the vulva. No, don't use soap. And water sometimes can be drying. And some of us, we use what do you call it? We use panty liners every day, which can be drying and irritating to the vulva, and it drains the vulva of natural oils. So we need to be using emollients to just make the vulva look healthy. And I always say, if you moisturize your face, moisturize the vulva. Vaginal moisturizers are different from vaginal lubricants. Lubricants are more for intimacy. We have the oil base or the water base, is personal preference. Moisturizers stay longer in the vagina. They can last up to 2 to 3 days, and they just help to keep the tissues there well hydrated so they're not too dry and sore. And that's it. So additional information there for anything else, nutrition, menopause matters, and so on. And thank you. Sorry to skip through. Thank you.
Funmi, thank you so much. I feel clearly like a complete imposter here, but I found that a really fascinating talk, really informative, but given in a very kind of open, calm, lovely way. So thank you, Funmi. I really appreciate you taking the time to do that for us.
Everyone's clapping.
Everyone's clapping. That's nice. That's nice.
Thank
there
you.
are no questions in the chat. I think people were kind of absorbed in the presentation, but if anybody has some questions, please feel free to bring them through.
One's come through saying,
can we unmute then if there's no question? Is that okay?
There are a couple. There are a couple coming through. So.
Okay. Oh, thank you. Sorry.
We'll pose them to you, Funmi.
If a woman is experiencing incontinence, is it ever too late to get help?
No, never, never. And you know that one thing I always say to all my patients, age is not a barrier to anything, right? Your pelvic floor, you can rehabilitate your pelvic floor at any age. It's never too late. And that's one thing, and I always say to all my patients, don't let anyone tell you what is expected of your age. You should leak, or when you have babies, you should leak urine or you should leak wee. No, that is absolutely incorrect. You should not experience such symptoms. And we women, we don't get help on time. I see men, I see male patients. Do you know men cannot stand that rubbish? They can't, because people say, oh, do men have problems with continence? And I say, yes, they do. When they have prostate surgery, they do. And men cannot even just, they just can't stand that. But we women, we put up with it for years. We should always seek help. It's never too late to strengthen the pelvic floor.
Funmi, a long time ago, you described how to do pelvic floor exercises to me and to the rest of the team. And it was an eye-opener because I've only ever concentrated on one area of what I thought of the pelvic floor. Would you be happy to describe now how you describe it, or would it be better to do it?
Okay, yes, I can. So, I showed you the pelvic floor. The pelvic floor is like, I always say, think of it like the bottom of the bowl, right? So the pubic bone is in front, and you have the coccyx or the tailbone at the back. So if you put your hands together sideways like this, the bulk of the muscle is at the back, close to your close to your coccyx. That's your tailbone. Sorry, I just had it. So it's at the back, close to your tailbone. You want to start your pelvic floor technique from the back passage, right? You imagine you are pulling up the back passage and then you bring in the front. Many people clamp when they are doing pelvic floor, or they are using their bum cheeks, or they are using their tummy. And I say, no, that is absolutely incorrect. You always start from the back passage. Is a lift from the back and then you pull in. So you draw up the back and you pull in the front. And everybody's strength is different. And we can strengthen them. We have to have some hold and some quick contractions. Because in the pelvic floor, we have the fast muscles and we have the slow twitch muscle. It's a very difficult muscle to strengthen sometimes, but you can do it. And you just need to understand and you'll get there. So the way I describe it, you have the Mo Farahs and the Usain Bolts. You have to keep training the Mo Farahs and the Usain Bolts together. Does that make sense? You have to train the long distance runner and the sprinters together. So it's easy to do, but you just need to get the technique. So you always start from the back. You lift and you bring in. See how long you can hold for. You rest for like 4 seconds and you repeat as many times as possible. And then you do the quick ones as well. And you need to make sure you do them 2 to 3 times a day. Some people say, oh, I've been told to do it in the supermarket while I'm on the queue. No. If you can't even do it sitting, you can't do it standing, forget it. So that's why I say you need to first know how to do it before you start going into what we call functional rehab. And if you are struggling to get to do it, then make sure you get help. Even if it's just one consultation, have one consultation, get checked properly, right? And then you can be taught how to do the exercises correctly. So somebody is asking for the doctor's name. She's Melanie Tipples. Miss Melanie Tipples. Yeah, okay. Any more questions? Can you hear me?
Yeah, hear you nicely, clearly. Thank you. Thank you.
Yeah, no more questions.
No more questions coming through. We will certainly, with Funmi's blessing, we will post this video. So if you want to refer anybody to it in the future, you're welcome to. And if there's any information that you've missed along the way or you joined late, that way you can catch up. Funmi, there are a couple of things. Just the probiotics, I think that you were suggesting were recommended, the Optibac and Simprove. Are they easy to find? Is that something that...
Yes. Yeah. Yes. If you are suffering with constipation, it's also important that don't just start all this. It's good you talk through, because there are different types of constipation. It's not just only the diet. Sometimes people's pelvic floor muscles can be too tight, then you can't poo, or it can be too, it's not just letting it out completely. So even if you take the probiotics, if your pelvic floor is too tight, you may struggle to poo. but that's not a lot of people. But if you know the pelvic floor is not too tight, it's just that the poo is hard, then probiotics will help, or you get a lot of IBS symptoms. So we use Simprove or Optibac. You can get it online.
Okay. Well, we will put that in the. We'll put those two products in the as a reference as well. That's great. Thanks again, Funmi. Really, 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 really good talk. Thank you all very much for coming along to listen to us, listen to Funmi.
Thank you.
Thanks
for the feedback,
Thank you,
everyone.
Really good.
Brilliant. Thank you.
We hope to see you all soon.